Please welcome our speakers for our next session, Drs. Nicole Davis and Varian Evans. Dr. Davis is an associate professor and the adult gerontological nurse practitioner and MSN education program coordinator at Clemson University School of Nursing. She is a board certified adult and gerontological nurse practitioner with expertise in urinary incontinence and using health information technology to support family caregivers. Dr. Evans is an assistant professor of health education in the Department of Health Sciences at South Carolina State University. And prior to her career in higher education, Dr. Evans spent many years working in public health as an environmental health manager, program information coordinator, and health promotion manager. Today, our speakers will lead our third session entitled Research Guided by Statewide Alzheimer's Disease Registry.
So good morning, everyone. So as Dr. Ingram said, I'm Nicole Davis. I'm an associate professor at Clemson School of Nursing, also the graduate program coordinator. And I'm also a former CADMIR pilot project awardee. So I'm extremely honored to be here discussing my project with you. So the title of the project is Sociodemographic Differences in the Prevalence of ADRD across South Carolina. Next slide, please. Before I begin, I really would like to acknowledge the funding and the support that I received for this project. I had wonderful mentors, and it was an amazing team led by Drs. Lefkoff and Friedman. Next slide, please. So among this group, I understand that ADRD, the demographics, the aging demographic trends is well known. Next slide. But when we look at South Carolina specifically, just to give you a little bit of background, within South Carolina is the eighth highest Alzheimer's disease, has the eighth highest Alzheimer's disease death rate. Since the year 2000, we've seen a 192% increase in Alzheimer's deaths. And in 2017 alone, there were over 2,500 Alzheimer's related deaths. Next slide. And when we think about just generally the socio-demographic impact of ADRD, studies continue to show that beyond simply genetics, when we think about social determinants of health, variations in lifestyle, socioeconomic risk factors, those account for most of the differences when we consider who is at risk for developing these devastating diseases. Next slide. The purpose of my project primarily was to determine whether sociodemographic factors, for example, race, gender, or geographic location, whether or not those factors contributed to ADRD prevalence across counties within the state of South Carolina. And then secondarily, to examine the variation of health utilization across racial ethnic groups between urban and rural counties and by their associations with ADRD types and other health-related outcomes. Next slide. So to address these objectives, we analyzed data from the South Carolina Alzheimer's Disease Registry, and then using patient-specific identifiers, we merged the data with the South Carolina Revenue and Fiscal Affairs Office data. And then we also did some geospatial mapping using geospatial technologies, really just to look for any areas of concern, hotspots that would be something that we would need to focus in on. Next slide. So again, with the geospatial technologies, very fortunate that we have a geospatial technologies department here at Clemson. So we worked very closely with them for a long period of time. But again, just trying to visually display the health utilization data to help us identify perhaps specific regions that are underserved or need particular attention. Next slide. So I know Dr. Miller spent a lot of time talking about the Alzheimer's Disease Registry, but just to give you a little summary here. So we are very fortunate within this state to have access to it. It is the largest and most comprehensive registry of its kind within the United States. About 250,000 at least cases have been captured since its inception. And again, there are multiple sources of the data: emergency departments, long-term care evaluations, et cetera. And ADRD types within the data set are classified by ICD-9 medical codes. Next slide, please. The South Carolina Revenue and Fiscal Affairs Office, their overall mission is to provide independent research, analysis, and resources to facilitate informed policy decisions and also administration of services. So they collect data and they maintain data related to health, sociodemographics, health utilization, for example, ER visits, hospital admissions, uniformed billing data, diagnosis and procedure codes, just really a wonderful wealth of information that's available. For the purposes of this particular project, we focused in on hospital admissions when we looked at health utilization. Next slide, please. Okay, so here are some of our results. So when we analyze the data from the South Carolina Registry, we looked specifically at the years 2010 to 2014. There were 65,535 cases. The majority were women at 62%, white at 68%. When we looked at racial breakdown, 29% were African American. And what was interesting was that the Hispanics and those who chose other in terms of their racial backgrounds, almost non-existent, within the data set. So, that's just a point for future consideration. In terms of age, more than 90% were over the age of 65, 29% resided in rural counties, and 70% resided in non-rural counties. Next slide, please. So our definition for rurality came from the South Carolina Rural Health Report, and it's based specifically on population size, so nothing related to economics. So urban, if the largest town within that area had more than 25,000 people, it was considered an urban, county. Rural counties, if their largest town was less than 25,000 people, and very rural, if their largest town was less than 10,000 people. Next slide, please. Okay, so what this picture is showing you is the breakdown of counties within South Carolina by rural status. The white is showing you urban counties. Pink is showing you rural counties, and yellow is showing you very rural counties. So as you can see, the majority of South Carolina falls within the rural categories, and then there's a good percentage that are considered very rural. Next slide, please. When we looked at the distribution of dementia cases, again, from 2010 to 2014, according to the registry data, Greenville and Charleston accounted for the greatest percentages of dementia cases. And that's what you see in the far right-hand corner. The column to the far left, the colors there just align with whether or not it's rural versus very rural versus urban counties. Next slide, please. Distribution of dementia cases by rurality. So what you can see here, and in the rural category, we combined the very rural, but I broke it down here just so you could take a look at that and see it there. But in terms of frequency, 70% resided in an urban or non-rural county, and 30% resided in a rural county. And this was pretty interesting because it's consistent with the overall population of South Carolina, just generally, where 70% of South Carolinians live in urban counties, 29% live in rural counties, and 18% live in very rural counties. Next slide, please. So this slide is showing you case characteristics. When we looked at the characteristics in terms of age category, greater than or equal to age of 75, female, racial, white versus African American, and then also dementia type, what we found was that in terms of prevalence, it was pretty equal when you compared rural versus urban counties, except when we looked at the racial breakdown. We saw 72% of the white persons within the database were in urban counties, and 40% of the African Americans were in rural counties, and those represented the majorities. Okay, next slide, please. Excuse me. So ADRD prevalence in South Carolina among socio-demographic factors. Overall, what we found was that the ADRD prevalence was highest in persons who were over 65. It was also highest among those who were over the age of 85 more so. It was highest among whites, females, and within urban counties. And Alzheimer's was the most prevalent form of dementia that we found. ADRD prevalence among African Americans was higher in rural counties compared with urban counties. And then the prevalence of dementia type was similar across rural and urban counties. Next slide, please. The secondary objective of the project was to examine the variation in health utilization across racial ethnic groups between urban and rural counties and by their associations with ADRD types and other health-related outcomes. Next slide, please. Okay, so what we found, what I have to say is that the health utilization data, it was pretty much categorical data. So there were some limitations in terms of the analyses we could run, but we did find statistically significant association between dementia type and also gender, with Alzheimer's disease being the most prevalent between the two genders. And then we also found a statistically significant association between race and dementia type, with Alzheimer's disease, again, being the most prevalent in all of the racial groups. Next slide, please. Next, we did some mapping using geospatial technologies. And what this slide is showing you is not the greatest map, but a map nonetheless. So what it's showing you is the number of emergency room visits between 2010 and 2014. And there were over 1 million emergency room visits within this population. The darker orange represents greater than 17,500 visits. And that scale goes down to the yellow, which shows less than or equal to 1,280 visits. Next slide, please. When we look at that breakdown compared with rurality, it seems that there was a larger concentration of emergency room visits around the major cities, regardless of rural status. And one area particularly that was interesting, if you can see my cursor, is this area here, this part of the state. Even though they fall into the rural and very rural categories, there was still a high percentage of emergency room visits within these three counties. So that is Clarendon, Georgetown, and then also Williamsburg here, which is interesting. Next slide, please. We were also able to pull some data from HRSA and map that and sort of take a look at the locations of certain medical facilities. So hospitals registered with Medicare, nursing homes, veterans medical facilities, and other health center program sites is mapped here in this right picture. And what it showed to us was that there was a large concentration of nursing homes within this area, and any area that had a larger concentration of nursing homes also showed to have higher rates of emergency room visits, which was also interesting. Excuse me, hospital admissions. So lessons learned, this was my first project where I worked using databases. So it's not for the faint of heart. It's not as easy as some people may think that it is. Takes a lot of time, thought, and effort, but you always go into these things with a positive frame of mind and you hope for the best, but you really have to anticipate delays. Some of the delays that we saw with our project was really getting the approvals in the beginning. There's a certain process that goes along with getting the data, and then also actually having the data transferred to a secure server on the university side of things took a little bit of time as well. And then I have to say the work, continues. The more answers we get really generate more questions. So now we're looking at more descriptors related to payment sources, hospital length of stay, whether or not they were admitted from the nursing home versus the community, and looking for any associations among those things. Next slide, please. And so in conclusion, what I have to say, I just really want to thank the wonderful team that contributed to this project and wonderful mentors. And that's all that I have. Thank you.
Great, thank you so much, Dr. Davis. So great to see your work come to fruition. Just remember, your proposal and things. It's so great to have an opportunity to see all of the hard work that you did put into what you were doing with the registry data. So now we're going to have Quentin share Dr. Evans.
Good morning. I'm Dr. Varian Evans from South Carolina State University. As Dr. Ingram stated, I am an assistant professor here at South Carolina State, and I also serve as the Quality Enhancement Plan Director. South Carolina State, for those of you who may not be aware, South Carolina State is an 1890 land grant institution located in Orangeburg, South Carolina. And I bring you greetings from Bulldog Country. Today, I'm going to be talking with you about my academic project, which is entitled Patterns of Multimorbidity and Behavioral and Psychological Symptoms in Individuals with Alzheimer's Disease. Next slide. My presentation will provide you with a background of the study, its purpose, and brief summary of the literature review, as well as a discussion of the methodology and results and conclusion. Next slide. Based on the most recent demographic shift in both age and racial composition, the minority population will greatly increase. There is the likelihood that older African Americans will be at a greater risk of Alzheimer's disease as compared to whites, which we've heard several times this morning. Along with Alzheimer's disease come the increased risk of multimorbidity. Behavioral and psychological symptoms is also a common occurrence as dementia evolves. Studies indicate that mounting numbers of older adults are living with and managing multimorbidity, which is defined as the development of two or more chronic conditions such as hypertension, diabetes, obesity in one person. Multimorbidity often results in complex healthcare needs and presents serious public health concerns. The prevalence of multimorbidity ranges from 55% to 98% among older adults. Furthermore, it imposes a disproportionate burden on older Blacks and whites due to earlier onset and greater severity of complex conditions Again, we heard this morning about the comparisons between races, blacks and whites. For older adults with Alzheimer's disease and related dementias, multimorbidity is common and may pose unique challenges. For example, in a study conducted by Tonelli in 2017, the study suggested that the burden of multimorbidity and dementia together are strongly correlated with adverse health outcomes and a proxy for loss of independent living. The relationships, excuse me, the relationships and patterns of multimorbidity in persons living with Alzheimer's disease and related dementia were not well described due to limited racial and ethnic diversity of study samples. The availability of the data for the South Carolina Alzheimer's disease registry overcomes some of these limitations, allowing our study to deepen our understanding of the multimorbidity among older adults living with Alzheimer's disease. Now, in terms of behavior and psychological symptoms of dementia, and from moving forward, we're just going to refer to them as BPSDs. These are a source of considerable morbidity and are frequently the most challenging indicators of dementia and are exhibited in the majority of people who have dementia. Persons with dementia and BPSDs may behave in a manner that that may endanger themselves and others. In addition to being distressing to the individual with Alzheimer's disease, the presence of BPSDs has been shown to increase the physical and emotional challenges experienced by the families and caregivers. Up to 75% of patients with dementia develop at least one behavioral disturbance over a 5-year period or over the course of their ADRD. Now, in regards to inequalities in Alzheimer's disease and related dementia between racial and ethnic groups, we've covered that. Dr. Davis talked about it. Dr. Thorpe talked about it earlier this morning, so we're pretty much familiar with that. But per capita, older African Americans are more likely to have ADRD. Reducing that disparity is of primary importance. Additionally, a study conducted by K.A. Matthews in 2019 indicated that the prevalence of ADRD is highest among the racial and ethnic groups who are expected to experience the highest rates of population growth, and this comes from the U.S. Census Bureau. Our study aimed to do two things. The first one was estimate the most, next slide, please. Okay. Our study aimed to, one, estimate the most common clusters of multimorbidity in persons with Alzheimer's disease by race, and number two, estimate the association between multimorbidity and behaviors and psychological symptoms in persons with ADRD by race. This study used a subsample of data extracted from the South Carolina Alzheimer's Disease Registry, a population-based registry, which you've all heard a lot about this morning. It included data that reflects the significant and multifaceted impact of Alzheimer's disease on individuals in the state of South Carolina. A subsample of 641 individuals was extracted from the registry. Measurements for the study included multimorbidity, and we used the neuropsychiatric inventory questionnaire to actually measure the frequency of behaviors and psychological symptoms. And then the third measure we used was the agglomerative hierarchical cluster analysis, which was used to group participants according to chronic conditions. Regression models were used to examine associations between Alzheimer's disease, BPSDs, and morbidity. Multimorbidity was defined in two ways. The first way was is the total number of chronic conditions, and then secondly, is the clinical relevant clusters of two or more chronic conditions using agglomerative hierarchical clustering analysis. Next slide. Our results. The mean number of chronic conditions was 2.92 among whites, 2.85 among Blacks, and 2.89 among both races. Overall, there were no significant difference in the number of chronic conditions among the races. However, there was a significant difference in the mean neurological, psychological inventory score between the two races, whites being 35.489, Blacks 28.216, and 31.858 collectively. Of the 640 patients, approximately 95% had a chronic condition. Regarding behavioral disturbances, 90.4% of the sample reported experiences in delusions. By race, 37.5% of African Americans reported having delusions. The three most common clusters for whites include hypertension, anemia, arthritis, and osteoporosis, while common clusters among Blacks include hypertension, other cardiovascular disease, anemia, arthritis, diabetes mellitus, hypertension, arthritis, and hypertension. Next slide. More than 1 in 4 patients had at least one comorbid condition, and among patients with comorbidity, 1 in 3 had multimorbidity. The difference between comorbid is that a person has more than one condition at the same time. Multimorbidity means that a person has 2 or more conditions going on at the same time. The prevalence of comorbidity varied by gender, age group, ethnicity, and injury type. It was also associated with a significant increase in the average cumulative length of stay per patient. Okay, since we moved on to the next slide, 1 or more NPS were observed in 51.0% of participants. Depression was most common, followed by apathy and irritability, 17.7%. Least common were elation, hallucinations, and disinhibition. Stroke prior to the onset of Alzheimer's disease was associated with increased risk of delusions. Hypertension was associated with increased risk of delusions as well. Anxiety and agitation / aggression. There were no association observed between NPS and diabetes, hyperlipidemia, heart attack, or CABG, or overall health. And this was based on information from a study by Catherine Trieber et al. Okay, this table, table 1, the prevalence of comorbidity by race. Hopefully you all can see it well. By race, by white, African American, then you have total figures. The average age of the person in the study by white race was 83.08. African Americans was 83.82, and then overall was 83.45. If you remember this number from one of the previous slides, the mean number of conditions that a white person had was 2.9. So that means that they had it categorized as either comorbid or multimorbid. And African Americans, there were 2.85 conditions, and then An average total was 2.886. The mean score we just talked about in the previous slide as well, but I wanted you to actually see some of the conditions that we were actually analyzing, such as anemia, arthritis, atherosclerotic disease, congestive heart failure, diabetes mellitus, hypertension, and then some of the BPSDs included the delusions, hallucinations, agitation, depression, irritability, motor functions, and sleep. Okay. Next slide. Overall, participant characteristics, I just kind of summarized that just now in the previous table. But let me break this down a little bit more. The 5 most common chronic conditions were hypertension, arthritis, diabetes, anemia, and congestive heart failure. For whites, the 5 most common were hypertension, arthritis, diabetes, osteoporosis, and anemia. For African Americans, the 5 most common were hypertension, arthritis, diabetes, anemia, and congestive heart failure. Overall, the 3 most common BPSDs were agitation, irritability, and apathy. For whites, the 3 most common were agitation, apathy, and irritability. For African American, the 3 most common were agitation, irritability, and sleep. Okay. This particular slide, I know this is really hard to see. This is called a dendrogram, and all the the outside of the circle actually is an illustration of the clusters. Like when we talked about among the white population, the clusters included diabetes, arthritis, anemia. So you can't see this. This is really hard to see, but this is the kind of dendrogram or analysis that we actually used. Okay. Okay. Speaking of the clusters by race, and this is strictly by the white race right here. Cluster number 1, these people had hypertension. Cluster number 2, the people in this group had hypertension, anemia, arthritis, and osteoporosis. And then cluster number 3, people had hypertension, arthritis, and diabetes. And this was among the white race. Next slide. Okay, African Americans, their clusters number 1 was hypertension, other cardiovascular disease, anemia, arthritis, and diabetes mellitus. Cluster number 2, hypertension and arthritis. And then cluster number 3 was only hypertension. Okay. Next slide. Conclusions. This study is important for planning of public health programs, improving the quality of life for persons with Alzheimer's disease or related dementias. Our future research should expand the analysis that have been conducted, but in a larger sample. Again, our sample included 641 individuals. And these studies should also include other administrative or clinical data to further explain the relationship between multimorbidity and premature death in Alzheimer's disease and related dementias. Next slide. I'd like to also acknowledge Dr. Maggie Miller, the Registry Manager for the South Carolina Alzheimer's Disease Register, and she also served as my lead mentor. Ms. Sydney Smith, who was a graduate research assistant working alongside Dr. Miller. Also, Ms. Miranda Scott, who was my undergraduate research assistant here at South Carolina State University. Lastly, we'd like to also thank the CADMR team, the collective team, the MPIs, the project manager, core leaders, and the project mentors. And a shout out to South Carolina State University. Thank you for your time and your attention.
Fantastic. Thank you so much, Dr. Evans, for your presentation. And thanks to the both of you, Dr. Evans and Dr. Davis, for the work that you put into really illuminating the opportunities that the South Carolina Alzheimer's registries can provide. So thank you so much. So we do have several questions for you, and I will start with a couple of questions that are responsive to your presentation, Nicole. When we're talking about emergency room visits, are they directly related to the symptoms and circumstances that surround ADRD, or are they regarding diagnosing such diseases? Or are they tracking visits by those that have previously been diagnosed? Where do these data stem from?
Yes, and thank you so much for the question. So unfortunately, the health utilization data, it's limited in terms of specifically those specifics. We are looking at the admission diagnoses or the diagnosis for that particular visits, but it's hard to draw really any broad conclusions because it's just mostly categorical data or just data that they came to the emergency room or they were admitted to the hospital. Nothing related to symptoms related to Alzheimer's disease, but that's an excellent question. Thank you.
Right, a couple more questions about the ER visits. The first is about the map. So is the ER map data of ADRD patients who go to the ER or of total populations using ERs?
Yeah, I'm sorry if I misspoke. That's actually hospital admissions data. Not sure if that answers the question a little bit better.
Okay, and then we'll follow up with this one for the ER visits. Were these visits related to their Alzheimer's or other dementia or related to other diseases that the Alzheimer's patients may have had?
Yeah, I can tell you a lot of the work that I do is with genital urinary disorders. And when we looked closely at the ICD-9 codes, there were a lot of admissions related to like urinary retention. So a lot of things surrounding those things. That's part of how we're going to do more of a deep dive into the ICD-9 codes surrounding those visits, but that's not represented on the map.
Thank you. This one could be a question for either of you. This attendee says, I would be interested to see a study on the effects of the relationship between people with ADRD and their familial caregivers, the strain that might exist due to the disease, as well as what the caregivers have learned. I think that would be really beneficial for people that were going into that situation, as they would have a reference for what to expect, as well as ways to deal with the situation. Thoughts from either of you on that?
I strongly agree with that. It's so important that caregivers as well as family be taken care of, know what to do, and just I don't even know how to say it. Let me use an example. My mother is taking care of her 70-year-old brother, and this is so brand new for her. And it would be really good if she had access to some outside care, or somebody could actually come in and provide some other assistance, but just get a better understanding of ADRD.
Yes, I totally agree with Dr. Evans. And another project that I'm leading, we just finished caregiver interviews throughout the state of South Carolina to get a sense of what their thoughts about dementia in terms of how they see it and any resources that they need. And, I think it's from what we found so far, really, it's a population, as we all know, that needs a lot of help. And unfortunately, the resources are there. What I would like to see is, because in the qualitative project, we interviewed African American and Latinx caregivers, but the Latinx caregivers are very hard to reach. And we also see that in Dr. Miller, her work with the Alzheimer's disease registry. We know that they're there, the Latinx community, but how can we reach them? How can we engage them? That's a study I would like to see in the future, but totally agree. More caregiver work is needed.
Well, great. Well, thank you both so much again for the valuable work that you are doing with our registry data. Hopefully others, again, see kind of a practical example of the opportunities, just a snippet of the opportunities that one could have in terms of conducting research with uh, the registry that we have here in South Carolina. And certainly complementary work can be done with both Georgia and West Virginia. So now we're at the time for our lunch break. We ask that you please do return at 1 p.m., at which time we'll hear from Mrs. Jo Pauline Jones, Dr. Lisa McGuire, and Ms. Taylor Wilson about their work using data to guide state and national initiatives. Thanks so much.